Right, so today's webinar, we will be discussing the effect of government policy actions on longevity expectations. Maybe you subscribe to the view that the purpose of the state is freedom, and what greater freedom is there than being alive and healthy? Or perhaps you think the 9 most terrifying words in the English language are, I'm from the government and I'm here to help. Regardless of your political persuasion, what is hopefully undeniable is that the choices and execution of government policy do have some impact on changes in longevity. And with the anniversary of Labour taking over the reins of power approaching, it seems like the right time to evaluate what we've seen over the last year and what we might expect over the remainder of the Parliament that will affect our expectations of longevity. I'm delighted to be joined for this discussion by Stephen Baxter. Stephen is Chief Data Scientist at Club Vita, where he's responsible for thought leadership in longevity and architect of the longevity analytics within Club Vita LLP across the UK and North America. Stephen leads a multidisciplinary team of statisticians and actuaries in analysing predictors of longevity, emerging trends in later life mortality, and the implications of longevity uncertainty on the financial health of pension schemes and insurers. He has extensive experience of working with insurers, pension schemes and banks in pricing and managing longevity risk, and as an author of numerous articles and book chapters on longevity. Welcome, Stephen. Also joined by Lily Parsey. Lily leads the ILC's policy, public affairs and influence activity in the UK and across the world, looking at how to future-proof society in the context of long lives. Her work spans the future of health and care to intergenerational fairness, work and pensions. In the last 5 years, she's influenced the government's work on the state pension age, convinced G20 ministers to commit to increase funding on prevention, and informed the government's smoking ban. Lily sits on the advisory board of the Brain Health Alliance, the Age Action Alliance, and previously managed 2 innovation competitions supporting people to stay in work for longer and to support consumers at risk of vulnerability. And last but by absolutely no means least, we're joined by Steve Webb, who was the Minister of State for Pensions between 2010 and 2015. During that time, he implemented major reforms to the state pension system, oversaw the successful introduction of automatic enrolment, and played a key role in the introduction of pensions freedom, which happened in April 2015. He was awarded a knighthood in the New Year's Honours in 2017. And following his time in Parliament, he worked for Royal London for 4 years before joining LCP as a partner in 2020, where his campaigned successfully to secure an estimated $2 billion in back payments for over 100,000 women who are underpaid state pensions. And more recently, he has been working on proposals for reform of the DB funding system and on innovation ideas for decumulation in DC pensions. So, my welcome to all of you. For those attending the webinar, if you have any questions, please can you put those in the chat throughout the webinar, and we'll have time at the end to raise these with the panelists. So let's get the ball rolling, and we'll begin by reflecting on the past. Steve, what do you consider to be the most significant government actions in the past that have influenced longevity, either positively or negatively?
Thanks very much, Sacha, and good afternoon, everybody. I guess it slightly depends how far back we want to go. I asked this question of one of my colleagues, and he said, oh, well, the Public Health Act of 1858 was a good one. And it's worth remembering that, some of the very foundational measures we've seen on public health have made a huge impact on longevity. And I think the most useful way to think about this is I like Andrew Scott's analogy of the telescope, the extendable telescope in 3 parts, and that initially a lot of this was about preventing infant mortality and making sure people actually made it through their childhood. And then you extend the second part of the telescope, and people in working age are not dying of work, not dying of communicable diseases and so forth. And then now we're more focused on extending that final phase of the telescope. And I suppose key landmarks of government intervention would have to be the creation of the NHS in 1948. Things like, the whole things that follow from that, whether it's development in partnership with government and the private sector of new treatments, of mass vaccination programs and those kinds of things. And some things that are not necessarily directly to do with government policy, but where government policy has intervened more recently. A classic example would be smoking, where obviously smoking was having an adverse impact and grew and became more serious. But I was in Parliament when we voted for the smoking ban, and that's already started to have some beneficial effects. So I think, although it's tempted to be rather down on government, and we may think of some of the more negative things that have happened over the long sweep of history, it feels to me like a huge amount's been achieved.
Cool. Lily, you got any other thoughts on this question?
Yes, sorry, I was also struggling with finding the mute button for a second. Completely agree with Steve. It really depends how far back you want to go. Theoretically, things like having toilets and sanitation was pretty good for public health and life expectancy, I'd say. In terms of more recent things, again, extending vaccination from beyond just something for childhood to sort of life course, clearly something that we've done pretty well in the UK. If you compare to other countries, while not perfect, we're pretty good at coverage rates for things like flu, pneumococcal, and so on. And we know that there's a huge sort of return on investment, not just in terms of health, but also, work and so on. I think some of the other big successes lie in sort of regulation. So if we look at things like sugar tax, clearly very successful in terms of actually changing, companies and manufacturers' recipes in terms of drinks. So are there other areas where we could be doing some things where, particularly in the sort of cash-strapped environment that it looks like we're in at the moment, we can do relatively low-cost interventions that can have a big impact. And I guess more broadly, a move slowly, perhaps too slowly, but looking more to prevention. So, we know that, prevention is better than cure, ideally for people's lives, but also for healthcare costs, for capacity for people staying in work. And I guess just to add, clearly it feels like we've ticked some of the big boxes that have really brought some of the biggest improvements that we could see in life expectancy and healthy life expectancy. So we perhaps shouldn't expect quite as big gains with wherever we go next. But for one, that absolutely doesn't mean we shouldn't do it. And secondly, I think we have a huge amount to gain, of all the people in their 40s and 50s that are already too unhealthy to work, where actually we absolutely have the interventions and they're just not getting to people.
Very good. There are obviously different views, different actuaries, different academics take different views regarding the relative importance of individual choice and behaviours, medical and technological innovations, affluence and government policy. Stephen, if you don't mind, I'll come to you next. And how important do you consider government actions to be relative to the other catalysts for changes in longevity?
Oh, it's a tough question, Sacha, because as you mentioned, there is so much around the importance of individual choice, behaviours, what's down to medical and technical innovation, affluence, and how does that interact with government policy? When Steve and Lily were talking about, I think, the actions over the last almost 200 years, I think the comments spanned. One of the things that strikes me during that period is that we saw a material rise in the wealth of the UK as a nation. And that in itself was a catalyst for changes in longevity. We effectively saw a gentrification, the ability, people had private housing, people could afford the heating, we could afford the various fundamentals that drive forward rises in life expectancy. And some of that was definitely triggered by government policy, and some of it was broader. I guess maybe if we think about what's happened in the last 50 or 60 years, we've seen those material rises in life expectancy, especially at the end of the telescope that Steve referred to. But while we've seen those rises in life expectancy, it hasn't necessarily been enjoyed to the same extent by all. I expect many of us are familiar with the metro maps or the tube maps for the cities we live in, which show you only need to go a couple of stops for maybe a 10-year difference in life expectancy. And it's that inequality which is perhaps important. So in that sense, I think the government is a catalyst for maybe creating more uniform distribution of wealth, and health outcomes can be really, really important in terms of longevity. However, if we look at the more recent times, I guess a lot of the improvements have been more behavioural factors. I think it was Unal et al. Who looked at the improvements over recent decades in cardiovascular disease and attributed around 60% to behavioural interventions and 40% to medical interventions for cardiovascular disease. Now, some of those behavioural things were actually kind of more. Well, some of that was very much driven by government policy, routine blood pressure monitoring, the education programs around health, smoking advertising rules, etc. They all nudged behaviours. And so in that sense, the government policy can indirectly be a catalyst in the other areas. Personally, though, I think it's going to be the behavioural area, which is the key area for one of the key areas for future catalysts, and also one of the hardest to change. And there, the government role is probably in terms of being a nudge or an incentivizer, rather than necessarily legislating to achieve an outcome. And I suppose the final remark I'd make in this area, Sacha, is I think we need to be able to, is going forward, it's going to be the technological innovation that I think may well trump some of the other factors. You mentioned that in your preamble. I personally am very excited about our ability to leverage artificial AI for both enhanced medical care and discovery of therapeutics. And in this way, I think that could be a significant catalyst for future longevity gains. But again, it has an interaction with government policy, because government policy will ultimately determine how widely we as a population benefit from the potential these new catalysts have to offer. Will government serve to be an incubator, for example?
Yeah, Steve, anything you'd expand on that one?
Yeah, I mean, government has its hand in a lot of these things, doesn't it? But also other players have been important. So the workplace has changed dramatically. If you think of sending people down coal mines or breathing in asbestos in the course of routine work and all that kind of thing. So those have been pretty substantial changes, some of which have been driven by legislation, some of which have been global economic factors and so on. I think the changes in individual behaviour are probably going to become, as Steve said, more important. So a quick plug for the Club Vita podcast series. Perhaps Steve doesn't feel he can, but I'm very happy to do that. Enjoyed episode 1 of the 3rd series on the risk of living longer by John Schoenby from Swiss Re. Fascinating presentation on metabolic health, quite depressing. I looked at all the things I eat and looked at all the symptoms that a bad diet generates, and I think I ticked most of those boxes. And so I think there is a serious question about the role of individuals in all of this and how far government, as Lily says, government does a sugar tax, which is great, although I still consume a hell of a lot of sugar. So that, there's been some quite modest interventions. And I suppose my observation coming from a government background is it's always tempting to think, you arrive in government and think, right, I've now got all these levers and I'm going to pull them all. I'm going to change everything. And so often government intervention, with some notable exceptions, like mass vaccination or something, but most of them take a long time. And some of those deep-seated inequalities in health that Steve referred to have grown up over decades and decades. And although Michael Gove wanted to, improve the healthy life expectancy of the poor and all of that, well, he announced a 10-year plan, but I don't think it's happened. So I think we sometimes think that governments are more powerful than they are. I suspect we're only going to make progress on these things if all of these things are working together: the workplace and the way we work, technology, the individual behaviour, and government intervention, all of them coming together probably.
Can I just jump in there very quickly? And I think, on the work side, I mean, yes, absolutely, we're mainly not going down mine shafts anymore. But at the same time, there's a pretty big risk of, the work that most of us do at the moment sort of killing us with kindness. We're all sitting in pretty comfortable chairs.
Speak for yourself.
That's true. We once had someone at one of our conferences actually who said the best public health interventions you can have is a really uncomfortable wooden sort of chair, because it forces you to get up every sort of hour or so. I tried since then, when I work from home, to move room every hour, but you always forget. Anyway, so I think the role of employers becomes more important in some ways, because actually you have potentially very sedentary lifestyle. I think we did some work recently which found that young people walk much less now than they did pre-pandemic, and they walk less than older people, and actually, particularly for future generations, you have this really big risk that if lots of your education and then most of your work life is sedentary, you're going to have much more impacts of this as well.
Absolutely, good point. A change in government is often considered as a potential signal for a change in expectations. I know a number of longevity practitioners, when they're sort of considering their scenarios for future longevity, will vary those scenarios by which political hue the government has at the time. Lily, if I can ask you, what do you make of what you've seen over the last year? What sort of particular things would you look at and see as potentially influencing the level of improvement?
I think the reality is probably not a huge amount already, or yet, sorry. You know, there's a hope that some of the exciting things are going to come towards the end of this government as we get closer to election. Obviously, you know, at the same time, we've had lots of big changes sort of internationally, geopolitically, that have an impact as well. You know, in terms of probably so far, the biggest impact will probably be cuts to disability benefits that will have an impact on people's lives, on their life expectancy and healthy life expectancy. You know, the reality is, you know, tariffs will probably have a very big impact on people's cost of living, as a result on their health. You know, we've had of pension and poverty going down. At the moment, it's going up. We've got pretty high economic inactivity in young people. So I think at the moment it's not to be too sort of negative, but at the moment I personally haven't seen a huge amount of positives. You know, there's hope that the government will turn things around. You know, there are a lot of stated ambitions that are really positive. The focus on prevention, on supporting skills. But yes, sorry, I think that's all I could say at the moment, Sacha.
Yeah, and Steve, how would you make it, given, you know, and compare it to your time?
I find myself in the odd position of stepping in to defend the Labour government slightly. I mean, I think there are similarities from 2010 when I joined government and 2024, in the sense that in both cases we and they are very fiscally constrained. I don't know whether they're more fiscally constrained than they thought they would be. I strongly suspect they knew pretty well what was coming, and that does mean just in terms of just spending money on good stuff becomes very, very difficult. I think it's probably unreasonable to think the first 9 months of a change of government is going to result in much. I mean, 9 months is not enough to pass a law. Essentially, I mean, you literally can't get a law through Parliament in less than 9 months. So it's unlikely any, you know, a big piece of legislation like a smoking ban or something like that, it just wasn't going to happen in the first 9 months. And I think the other thing, you know, for those who are perhaps a bit disappointed, who maybe voted for the new government and are a bit disappointed, I guess the one caveat would be, in opposition, you have virtually no resource for policy making. You do a bit. But to be honest, it's seen as almost an obscenity to spend time sitting in crowded rooms discussing the finer points of your policy when you might not get elected. You should be out there knocking on doors, raising the money, leafleting, talking to voters, and then once you're in, you work out what you're going to do. And I think there's an element of that inevitably, that the concentrate, you know, Labour were so scarred by previous elections they thought they'd win and didn't. They were so determined to concentrate on just the process of winning an election that detailed policy, frankly, hadn't been done in my view. The biggest disappointment, I suppose, is, in my view, the delay on social care. It feels to me that that is an area where you're dealing with the most vulnerable, with people whose life expectancy could be improved, with the knock-on effect on the NHS as well. You know, that if you can't get somebody out of hospital because there's no social care for them, and then they pick up an infection in hospital, and you can't get people into beds in hospital because there are people in the beds who could, you know, all of that. So I think social care is quite a key to all of this, and that was disappointing to see that essentially kicked into the long grass. So I am disappointed in that sense, but I think probably we needed to have more realistic expectations of what they might have done in such a short period.
Yeah, it's good to get that sort of, you know, sort of that realism of how challenging being in government is. So let's take a look and try and think ahead over the course of the rest of the Parliament. We're thinking about what you've seen so far, Stephen. What do you expect to come over the rest of the Parliament with respect to this government?
I think, Sacha, first and foremost, we need to recognise the current political landscape. It's very much dominated by geopolitical uncertainties at the moment. There's well-publicised tariffs. We've got economic challenges. Lily's already mentioned how the tariffs may well have knock-on impact to the cost of living. I suspect government ministers are also at the moment really focused on things like the security of national infrastructure, how to secure Britain's position on the international stage, what's Britain's role in a world of increasing international conflicts, etc., all of which are likely to lead to some very challenging questions around how the available budget is distributed, and how are we going to make difficult decisions between some of those elements of security and taking the country forward for future generations versus the health needs of the country. So I think at the moment there's going to be some very tough decisions that the government is probably wrestling with, and those geopolitical considerations will, I suspect, dominate for a good part of this parliamentary term. Now, Steve, you mentioned the knocking on doors aspect of politics, and of course, as we reach to near the end of any parliamentary term, I suspect politicians and cabinet minds turn a little bit towards how are we going to win the next election, how are we going to be back in for another term. So as we approach perhaps as we start going to 2028, where we are with NHS waiting lists, where we are with the social care situation will become inevitably politicised, and that may be the catalyst for pushing through some items of the agenda in those areas. But I suspect we're going to see it quite late in this political term. In the meantime, I suspect we will probably see overall some challenges with the general health of the nation, not just because of the fiscal considerations, but I think we need to be very aware that the current global uncertainty does have a strong negative impact on the mental health of the nation. But Steve, maybe that door knocking, that's maybe something that you might have done in the former days, and better place to say how cabinet ministers look at things in the run up to elections.
Well, door knocking is certainly good for your longevity in terms of exercise, judging by some of the councils.
Well, yeah, the mental strain of the abuse you get less so, I think, probably. But yeah, I mean, I guess that we could see populist stuff later in the parliament. There's always a tension, isn't there? Because some of the things that are effective are good for people, but not necessarily what people want. You know, a sugar tax isn't a terribly popular policy with people like sugary drinks, but we kind of feel we ought, you know, the smoking ban was mixed. Obviously, people don't want to be in smoking environments, are very happy about it, but an awful lot of people were the people it was actually going to have an impact on didn't like it. So it's not always the case, I think, that measures you do to be popular near an election are necessarily the ones that have the most impact on health. And the other dilemma, I think, is the scale of everything is so great. You know, the size of waiting lists, the scale of under provision of social care, that even, you know, a chancellor says another £1 billion, and you think, wow, that's a huge amount of money, and then you discover it's helped 53 people or so. You know, it just does need mind-numbing amounts of money to make a big difference on some of these areas, I think. But Lily, what's your thoughts?
Shall I take the more positive approach? No, I completely agree. I mean, you know, on the positives, obviously, you know, there's a question as we get closer to then re-elect or elections, you know, what policy is going to come forward then. But in terms of what we know already, you know, the smoking ban will, by the end of the term, potentially have started having an effect, which could have some really big impact. We did a bit of, well, obviously that's not how it will work, but we did some modeling a couple of years ago, looking at basically if everyone stopped smoking today, what would the impact be across their lives? And you'd have, again, this probably won't happen, but if that was the case, you'd have an extra 2.5 years on average of healthy life expectancy, an extra 2 years of people staying in work, which is pretty big. I think the other relatively exciting thing that's happened so far already, that and Stephen mentioned AI, is the government's investment in AI that could have an impact here. So both looking at, you know, things around productivity, probably more looking at the real basics of sort of admin and stuff that might help in tackling some of these waiting lists. I think there are something like 40 odd different data entry systems within the NHS. And there's been some trials, for example, I think in Italy, where basically they've managed to feed lots of these disparate and sometimes, you know, just natural language notes into AI, which clearly isn't perfect, but can help consolidate some of this. So I think there's some hope in those kinds of areas. Clearly, in terms of actually supporting in places where we have skills gaps, things like radiology. Clearly, we already know that the AI can do pretty well as long as it's being watched by another professional. There's a big NHS tender out at the moment, I think, of a few £100 million, which again is just looking in areas, but I think so there's some opportunity there. The focus, West Streeting's focus on prevention, and the announcement a couple of days ago on potentially introducing sort of personalised health MOTs, I think could be promising. So, so just to give the slightly positive spin, I think there are some things that seem to be happening despite the kind of tight environment that could have an impact.
Yeah, that's good, and it's not as much as it's fun to critique. I think let's try and set ourselves a bit of a different challenge in the next question, which is sort of what would we like to see happen over the Parliament, and obviously that's a wide-ranging topic. So let's start with we'll pick on 3 or 4 areas. Let's start with the NHS. Steve, can I sort of ask for your views on what you'd like to see happen with the NHS over the course of the Parliament?
Yeah, sure. And it feels though there is huge potential here. If NHS has at least been prioritised for what public spending there is, so that's got to be a good sign. I guess probably highlight 3 areas. I mean, one would be, when you look at the crude figures, if someone dies young, as a young adult, what are sometimes called, the deaths of despair and suicide and drug addiction and that kind of thing, that actually has a massive impact on the overall picture, on what has been a tragedy, big impact on the figures. One person dying 60 years prematurely is the same as 60 people dying 1 year prematurely, kind of thing. So actually tackling that, as well as being humane and urgent, would have a big impact on the numbers. And this whole area of deaths of despair and policy on drugs and on mental health for younger people that Lily mentioned feels to me like an urgent priority. And it's a cliche to say mental health is a Cinderella area, but it so often can be. So I think intervention, particularly on younger people's mental health, would be a very valuable thing to do. I guess the second thing at almost the other end of the scale is just that NHS urgent care. Sitting in, there is hard evidence that sitting in an ambulance outside an A department can be terminal. That whole business about people just waiting to get that urgent treatment. So prioritising, I think, NHS urgent care and some of the key elective waiting lists would be the second thing. And then I think the third thing is back to that, it's metabolic health, it's obesity, it's diabetes, it's those kinds of sets of issues, liver disease in middle ages and all of that. And we just don't know, I think, yet whether the anti-obesity medications are going to be a game changer. There is some evidence from the States that started to change things quite quickly. Obviously, there's questions about, side effects and who gets access to it. But a piece of work we did at LCP, we looked at the way these medicines are evaluated. And at the moment, it's very narrow. You count the benefits to the individual and the savings to the NHS. But if it saves you, for example, someone doesn't go off sick because they're not obese, and you save a fortune in disability benefits, they don't count that. So you can do something that would be massively positive for the public finances, but doesn't get credited. So we underconsume many of these interventions. So a new framework to value these things properly, a spend to save, if you like, that does involve upfront spending, but yields benefits to the individual, the employer, and the taxpayer, feels like an urgent area for me.
Yeah, that's a really good point in the sense of, we know economically things are challenging and heavily disrupted, which may or may not settle down. We know that the government's fiscally constrained, and prevention measures may be a way of delivering more bang for the buck. So we talked about obesity. Does anyone have any thoughts on other prevention measures that might be, they'd like to see brought to the public? Lily, do you have any thoughts on that?
So, sorry, the connection went for a second there, so I didn't quite hear your question.
Yeah, I was just talking about Steve was talking about the prevention measures, and I was just sort of widening out to ask about what other prevention measures think should be brought to bear.
Yeah, well, I think the first thing is we do, we have some pretty good interventions already that work, that just too few people get in front of. So, vaccination still not enough people take up, but actually it's pretty widespread. But, you know, when we look at things like screening uptake, when we look at, you know, lots of the things that are relatively low cost, we're not quite there yet. I mean, there's a big trial potentially of metformin, which I guess is a relatively promising one. So the, you know, diabetes drug that there seems to be some evidence that it could basically prevent a huge number of different things and is relatively low cost. So again, that could be a potential area. And then I think the question around behaviors. So in what sense the health system can really support people to take up the right behaviors, to stick with the right behaviors. So whether that's, you know, notification systems, whether there's fun ways of tracking, of gamifying, of, you know, creating a little bit of community around these things. You know, social prescribing sort of got a little lost, I feel, in COVID coming around. But I think, you know, there are some real opportunities of, again, relatively low cost interventions. But if you can create a real incentive that's more than, oh, it's good for your health and it will prevent you from these terrible diseases, for someone to pick up, you know, a running group locally that also is fun and sociable and is close to things they want to do anyway, then actually those are the sorts of interventions that will have really big long-term impacts. You know, like Stephen said, I think earlier, most of the sorts of diseases that are killing us and keeping us unwell are behavior based, and that's where we really need to intervene.
Yeah, absolutely. Stephen, can I bring you back? And you did talk about individual behaviours earlier. Do you want to sort of expand on anything else on this topic that you'd like to see the government tackle?
Yeah, certainly, Sacha, and I absolutely agree with both Lily and Steve that that anything we can do to gradually move the health surface towards more of a wellness and a prevention surface than a sickness surface has got to be good. The challenge is, as Steve alluded to, is the urgent care and making that transition. And in that regard, the more we can do to encourage healthy behaviours and as a preventative method, clearly hugely valuable. I always struggle with this one though, because we know behaviours are notoriously difficult to change. We probably all know somebody who smokes, and they probably know how dangerous it is for their health, but they've made that elective decision. In the same way, I love this time of year. The Easter Bunny comes and visits, and I've got a surfeit of chocolate to gorge myself on. Now, I love chocolate. I know it's bad for me. I know it's bad for my weight gain. I know it's bad for my body, but I get a lot of utility and enjoyment from eating the chocolate. Am I going to stop doing that? No. So I think we need to think how the policy can incentivize changes in individual behaviors which would have the biggest impact. And for me, they're really probably around diet and exercise. They're the two areas which we know lead through to so many diseases of later life, be it cancers, cardiovascular disease, through the health of the gut, potentially through to dementia. So we know that is a mechanism. Those mechanisms of healthy diet and exercise participation are crucial behaviors. So yes, as Lily says, you know, anything we can do to encourage people to exercise more, anything we can do to remove financial barriers to healthy diets have got to be good. But ultimately, I suspect government policy, as much as anything in prevention area, has got to be around moderating the impact of individuals' choices to make those decisions to eat chocolate, have sugary sweets, smoke, what have you. And so in that regard, I think the availability of the anti-obesity drugs, the likes of the Ozempic and things, clearly helpful as a potential moderator to the decisions we make. I personally think the sugar tax is the start of perhaps the new smoking effects that we see in longevity. In the sense, it's a start, and we'll see that probably grow momentum in terms of more impact on our diets in the future. And I've certainly heard people mention at least the attractiveness in the early part of a governmental term, maybe not just before election, but of the possibility of things like a salt tax or a tax on processed food, something that can maybe change the nature of the food products that we are choosing to consume. These all seem that sort of thing seems relatively impactful and easy to implement. I think many of the other big ticket things we could look at around sort of NHS preventative methods have a large price tag associated with them, and I don't think the Treasury's currently got an overflowing wallet for that capital investment.
And just a quick thought, Stephen, on salt taxes and processed food taxes. I guess I'm not sure I share the optimism that these things are easy to implement when you think how long it took to negotiate the sugar tax. So I think, you can just imagine all the vested interests protesting at salt tax and all the rest of it. And I think there is a distributional impact of all these things. If people on low budgets tend to overconsume unhealthy food, and that's what you tax. Now, you might say, well, they'll be very price responsive, so they'll switch to something else. But if they don't, then you are really hitting the poorer people. So although you raise some tax revenue for these things and you could spend it on the health service and preventative care, I think it's an area where you have to tread quite carefully. And I think for me, the key is evidence-based behavioural interventions. We've seen in pensions, the nudge, the auto-enrolment, switching the default, everybody stays in, everybody's in the default fund, nobody had to be forced to do anything, but the behavioural influence is just so powerful. And so it's not a matter of us wagging fingers at people, which we know generally doesn't work. It's working out what nudges, what social norms and so on we can use that do work, but it's got to be evidence-based, not our gut assumptions about these things.
Absolutely, Steve. And as you say, it's got to be nudges that don't create disadvantage some parts of society in a way we would have unintended consequences. So I like, for example, the encouragement for not having sweets at the cash tills anymore. So people still have the choice to buy sweets, but it's made it just that little bit harder. Putting fresh fruit and veg at the cash till. I fancy, we're not going to make people overnight want to snack on a banana, but we can make it easier for them to make an elective decision like that. Similarly, if you tax an undesirable food, you've got to make an alternative, an affordable alternative. Otherwise, as you rightly say, you don't have the net impact. And we need the education around it, which is very, education programs, relatively speaking, are not that, I would argue, not that expensive. Running a government advertising campaign is, compared to overhaul of the NHS, is, for example.
Can I just add one point? I think the choice architecture thing of where do you put things and what do you offer people is really important, and I think that is where there's a bigger space for regulation as well. So if you look at is there things you could include in planning, for example, around basically tackling sort of food deserts, so that you can't have neighborhoods where literally you can't access any healthy food. Could you be more prescriptive in terms of things like access to green space, and that kind of thing? The same way that we've managed to get in regulation around sort of affordable housing having to come with big new developments, could we have other things like that? Because I think it is really important that if you have no, if you have to massively go out of your way to make the healthy choice and you have a million other priorities, you're just simply not going to do it.
Really good points. Is there any other action that people would like to sort of raise that they'd like to see before I sort of move on to sort of the next question? I want to make sure we've covered everything. Okay, and just a reminder, we've had a question in the chat, which obviously we'll come to shortly, but if anyone has any questions, get them in, and we'll pick those up. So flipping this on its head for a moment, we've been talking about the effect of government action policy on longevity. So let's consider it from the other angle. I mean, we've seen incredible improvements in longevity over the last century, and expectations of life at retirement are now almost treble what they were when the state retirement age of 65 was brought in. So let me ask a question of what changes do you think the government should make in response to longevity? And Lily, can I bring you in on that one first, if that's all right? Sure.
And well, I think we could have a whole event on this, or a whole series. Clearly, there's a really good news story, as in we're living longer. There is an opportunity, by 2040, 63p in the pound could be spent by older people. People are working longer, but the problem is we haven't really quite turned it around yet. Government has to respond. So the key enabler, or, what's stopping us, I guess, from staying active is poor health. So there's over 1.5 million people between 50 and 69 that really want to work but can't, and mainly because of poor health. And we did this work back in 2014, I think, where we called it the missing million and redid it last year, and now it's 1.65. So there's, that feels like one of the biggest areas that we really need to kind of reframe and look at how we can keep people in good health. We probably also need to look at, some of the fiscal impacts, so things like increasing state pension age, just for sort of long-term sustainability. Now, at the same time, clearly making sure that we have benefits that cover people who can't stay in work for that long, and the reality of keeping people in work longer, which I guess is one of the feels like one of the biggest impacts and where government action is needed most. Healthy life expectancy in Blackpool is 55. Even if we had a state pension age that no longer increased, that obviously means that people simply won't be able to work as long. So if we're talking about longer working lives, we're not necessarily talking about people working to their 70s and 80s. There's some people who are able to might do and might want to, and in fact there's a lot of evidence that good work and purposeful work actually improves your health. Some of the biggest impacts we could have is if we increased average working life expectancy by a year or two, then actually the kind of fiscal issue of aging is almost solved, particularly if you have people that are at that point paying into their own pension, not drawing down on benefits, not drawing down on any other kinds of pensions. But the reality is that that's the really hard bit, right, of keeping people in midlife in work for longer. At the moment, so we have this thing called a Healthy Aging and Prevention Index that looks at kind of different countries across the world on all sorts of ways of how well are we adapting to long lives and how well are governments adapting. In the UK, we spend about 31 years across our lives in work on average, and that's come down by about 6 months since the pandemic. So whereas we clearly might not have to work to 70 or 80, 31 years across, these long lives clearly is too little. So increasing that by a few years. So that's, looking at workplace flexibility, keeping people healthy, making sure the work we're doing is keeping us healthy. I think that would be the biggest way in which government sort of needs to adapt, and clearly where they're looking in part as well, because it's a big driver of growth, and that's the kind of key mission.
Very good. Stephen, would either of you like to sort of come in on this question?
Well, maybe just one, because as Lily mentioned, state pension age. I haven't been asked to do the next review. We've had two, but the government haven't implemented the recommendations on either of them. But I've got a cunning wheeze. I have a cunning Blackadder plan, which is at the moment the argument against raising the state pension age is the people in Blackpool and some of the people you leave behind. And what if the Treasury was only allowed to increase state pension age relative to not average life expectancy, but the life expectancy or the healthy life expectancy of the poorest quarter of the population or something like that? Because that would give the Treasury a massive fiscal incentive to give a damn, frankly, pardon the language, about the people at the bottom of the pile. We get reports about it and we talk about it. And the phrase low-hanging fruit isn't quite right there, but for the people whose lives are foreshortened, doing something for and with them has the biggest bang for your buck. And it's not about me, relatively prosperous, perhaps having another 6 months. It's somebody not dying 10 years early in Blackpool. So I think if you found a way to rig the system so the Treasury actually cared about and did something about the people at the bottom of the pile and their healthy life expectancy, their life expectancy, you'd have a win-win, I think, there, because you'd get beneficial outcomes. The Treasury could then get some money back through longer, later state pension age. So that I think you could bring that together, because if in terms of extending the telescope and all the rest of it, we've sort of almost this part in that middle that we could do more on, and it's the people at the bottom of the pile.
Yeah.
Sorry, Stephen, go ahead.
I was just going to say, I was going to very much echo the thematics of Lily and Steve there, which was really about to my mind, we often talk about increasing life expectancy and longevity, And it's really that shifting narrative that with aging populations, it's about health. So it's not longevity for the sake of longevity. We want, as individuals, we want extra years to be in good health and have a good quality of life. And so shifting the narrative to our healthy longevity is really helpful. Like Steve's obviously was in Parliament when the state pension age reviews were going through. We were very much a participant in responding to things like the Cridland Review, and prior to that, I'd done a lot of work with Professor Sarah Harper and colleagues at the Oxford Institute of Population Ageing. And we concluded that whilst there was a variety of mechanisms which could result in fair outcomes, probably the best mechanism of all was to come up with an effective measure of healthy life expectancy and link that through to policy. Because as both Steve and Lily said, if we can increase the healthy life expectancy, people stay in work longer, that's great for the economy, the real economy. But also we can then have more unilateral state pension age increases without a substitution effect of people falling back on alternative benefits and not really creating any kind of treasury saving. So for me, taking the healthy life expectancy and enriching it with Steve Webb's cunning ways would be very helpful. I think the other thing we haven't really touched on, but really important in this area of increasing longevity, Sacha, is those healthy years for many of us happen obviously at the end of life. And that's creating a real challenge with the older age care sector in the UK. I expect many people on the webinar have had personal experience of that. And from my own personal experience of dealing with that system, I sympathise with you. I think more government-led reform, more clarity on building on the proposals and things like the Deal Not Review would be really powerful things in those areas in response to rising longevity.
Yeah, you're absolutely right. I mean, and Steve mentioned that earlier, that social care is not, well, if I can use an anecdote as my one, it's not in the long grass anymore. It's diving into the bottom of the ocean, and probably doesn't seem like it's going to be rearing its head anytime soon. We have got one question in the audience, but before we sort of move to those questions, and there's another sort of reminder for people, if you do have questions, to stick them in the chat, is let me just sort of put you guys a little bit on the spot. And ask you what level of change in actual longevity or expectations in longevity resulting from government actions would you expect to see by the end of this Parliament? So I'm giving you a couple of ways to answer it, depending on how brave you want to be in your answer. And let me come to Steve first, if that's all right.
Thanks a bunch. Yeah, no, I mean, I think over the short term, it's very hard to be very optimistic. We've talked about some pretty generational, slow-moving trends with deep-seated roots, if I can mix my metaphors. That some of these, decades of unhealthy lifestyles don't get fixed by a pill, kind of thing. So I think in the short term, in the next few years, the general consensus that I've been able to pick up is that the pattern we've now established of pretty slow improvements looks set to continue. I think the big unknown, and it is sort of technology, it's AI, it's kind of personalized medicine. You can kind of imagine, well, it's, when you read Steve Jobs' autobiography and the amount he had to pay to have his individual genes sequenced and all that kind of stuff, and it looks like the dark ages almost when you think of how easily we do these things now. And you sort of feel it could be the case that really the answer to so many of these things would be some form of personalized medicine. I'm not the world's leading expert on that, but it seems to me it's been talked about for such a long time. But if you could somehow tailor these interventions to our individual needs and circumstances, that could be a game changer. It doesn't feel like that's going to happen in 3 to 5 years, but it does feel like the adoption of AI and related technologies, the use of AI on screening and diagnostics and all of that, that's the glimmer of hope. That I don't think will largely be driven by government. And that I don't think will largely happen in the next 4 years before the next election. But I think that's one of the shining things on the horizon for me.
Lily, what are your thoughts?
Agreed. I think the next few years we might not see huge changes. Particularly as we said, we're sort of fine tuning now. Some of the big things that have really improved longevity in the past have already happened. I agree personalised medicine could change a huge amount. I was at a talk with Brian Cox the other day, and apparently there's already a blood test that you could use today that can basically tell you which of your organs has what kind of risk factors, and based on that you could sort of intervene potentially 15 years early, which I think, you know, there are things there that are pretty hopeful. You know, by what point they get to, you know, us all as sort of average users of the NHS is, you know, is another question. But I think there are some advancements. I think AI, yes, in the sort of longer term on things like drug discovery, but really in terms of potentially helping on some of the operational and, you know, the kind of backlogs, the people dying in emergent, you know, in A&E hospital bays. Ideally, you know, if you can do some things there that help, I think that really does save lives and could make a big difference. And then finally, I think that other, you know, big group of people to focus on it is the people in midlife. And I think there's a role for regulation and for employers and so on there.
And Stephen, you get the last word on this topic as someone who sets expectations for a living.
Wow. Your question is essentially only looking out to 2029, so we haven't got that long for to be proved right or wrong, have we? But Steve, you referred to the that telescope, and I think we're not going to see much in the at birth life expectancy change. There's probably factors of death to despair, mental health, combined with some of the positives we're seeing later life that probably won't move the dial much on from birth life expectancy in aggregate. I probably am optimistic for some modest rises in middle and older age life expectancies coming through from some of the existing nudges. But where I'm more pessimistic is in that being universal increases. I think we're likely to see by 2029 a continuing widening in both period and cohort life expectancy terms of the gap across society. I just think of some of the strains that we're seeing in the health service, the benefit cuts we alluded to earlier, the drag of COVID. There's a whole accumulation of various things that have happened over the last couple of decades, which I think will continue to manifest in a widening of health and longevity inequality in the short term. I do have a lot of hope, though, for the longer term initiatives. And I guess I'd probably encourage us as members of the actuarial profession, Sacha, as well, to help shape the narrative as well. I know we care for, from the point of view of the pensions and the annuity industries, around the ultimate length of time people live for. But I do suspect that we could do a lot for societal benefit in terms of helping with more robust measurement of healthy life expectancy, because that feels to me like the way we're going to ultimately close the health inequalities, increase healthy life expectancy, increase overall life expectancy, and at macro national finances level is the key issue to address.
Yeah, I mean, it's a very good point in terms of, you know, transition from healthy to unhealthy, you know, the relative needs and adapting that. But there is a knowledge gap in the UK. You know, one of my personal sort of, you know, areas that I'm interested in is sort of, you know, what proportion of people are going to need, so, you know, care at age 65. If we could answer that definitively, that would massively help people in terms of planning. Right, thank you to the panelists. We're just going to sort of, we're coming close to the end, so I'm going to pick and choose a few of the questions. One area I don't think we've necessarily covered as much as we might have done is regarding productivity. So I'm going to read a question from Stuart. You know, do the panel think that AI in healthcare or some other intervention might solve the productivity problem in healthcare and prevent an inevitable increase in healthcare spending as a percentage of GDP? So I think we haven't covered productivity in NHS, or at least could say more. So would anyone like to tackle that one?
I'm quite happy to give some initial thoughts, Sacha, while others are collecting them. I think AI in healthcare is going to be very important for productivity. There's a number of, it does have there's some low-hanging fruit, and there's some things that are prerequisite on a more joined up data infrastructure for our healthcare system. The low-hanging fruit, I would argue, is just recognizing that medical professionals are incredibly skilled, incredibly well trained, but also incredibly busy. And that when you're busy and you're tired, you don't always tap into your memory banks as well as you would like to. And so the ability for AI to provide very simple prompts of, have you thought about this? Have you thought about that? Can actually materially improve outcomes. Equally, identifying medicines that are potentially going to have unintended interactive effects can be really helpful. So I know from speaking to a number of friends in the NHS, there's already quite a lot of pilot studies around these kind of prompts, and I think they can be very helpful. It's effectively replacing the innovation from a few years ago of putting the sign on the entrance to surgical theatres reminding all medical staff to wash their hands, which made a massive difference to surgical infections. Very simple. It's just people rushing from A to B, forgetting a very simple thing. So I think AI can really help with some low hanging fruit that would increase productivity in the NHS and healthcare.
Absolutely. In the interest of time, appreciate there might be other thoughts. I'm going to try and squeeze another question in. This is regarding the telescope analogy. So the question is longevity at the far end of the telescope an area that the government is incentivized to extend given the extra cost, and or does investment tend to be focused on extending healthy working age? And Steve, can I bring you in on that, on sort of what the view is, both from the politics and from the civil service? Because I imagine both are relevant here.
Yeah, sure. There's no doubt that enabling somebody, I mean, as Lily gave some of the figures, someone in their late 50s, early 60s, not to drop out of the labour market is hugely beneficial fiscally. There's no question about that, and that's why it's quite a significant focus of government action. For the very elderly, it's mixed. I mean, clearly, you have to pay them. I mean, being a calculating machine rather than being human about this, being the treasury, as it were, you clearly, the longer people live, have to pay them pensions for longer, the more risk of NHS treatment. I think it's that question about, are you extending the telescope and all the rough stuff comes right at the end? So actually they just get more years of healthy working life, in which case, or healthy life rather, which means that they're not making heavy calls on the NHS and so on. And that's just a kind of fixed period at the end. And indeed, potentially, if you get this right through more prevention, you can save the bills, because we know that there's a huge curve such that the cost of the very elderly is disproportionately large on health and social care relative to the fairly elderly. So if you can actually enable the very elderly to live more healthy, closer to the end of their life, there is a massive saving to be had there. So the prize is great for the very elderly as well, because that is where the extreme costs come. So I think, but I take the point. I understand that if it's just a few years longer and there's just more NHS cost and pension cost, you haven't saved anything. But if you can rein in those extreme end of life costs, then you've got a chance, I think.
Thanks, Steve. And unfortunately, we're out of time, so apologies to the people who've asked a couple of questions we've not got to. Let me end by thanking Steve, Lily, and Steve for taking part in this webinar and sharing your insight. That is very much appreciated. And my thanks to you, the audience, for attending and the questions asked. Until the next webinar, that's goodbye from us.
Thank you.
Thank you.
Thanks.